Good afternoon and welcome to the first session in the ISSUP webinar series on stigma and substance use disorder. Today's session is hosted by ISSUP South Africa and ISSUP United Kingdom. Just a little bit of housekeeping. The webinar will run for 90 minutes and this will be recorded and then posted onto the ISSUP YouTube channel and ISSUP website. Please feel free to also post any questions you might have for the experts in the question pane, which is located in the navigation box on the right of your screen. So why are we here? Well, illicit drug use disorder is the most stigmatized health condition in the world, with alcohol use disorder not far behind at 4th in the world. This is among a list of 18 of the most stigmatized conditions internationally. Importantly, the degree of stigma is directly related to the perceived cause of the condition. So if it's perceived not to be one's fault, the stigma is often lowered. And perceived control over the condition. So if perceived not to be under someone's control, stigma is lower. However, feeling stigmatized can reduce the willingness of individuals with substance use disorder to seek treatment. Stigmatizing views of people with substance use disorder are common. This stereotyping can lead others to feel pity, fear, anger, and a desire for social distance from people with substance use disorder. And lastly, stigmatizing language can negatively influence healthcare provider perceptions of people with substance use disorder, which can impact the care that they provide. So the language that we use to talk about substance use really shapes how the public views substance use disorders. Unintentionally stigmatizing language can perpetuate negative stereotypes about the type of people who are affected by substance misuse. This is the basis for the webinar series. We believe that starting the discussion about the language used in relation to substance use disorder is essential to the access and provision of treatment and to the strengthening of prevention systems that work on primary and secondary levels. Today, we have two experts providing us with presentations, Professor Liezille Jacobs and Mr. Paul Ashley. We will also be playing short videos of individuals with lived experiences. Thank you to the ISSUP South Africa team, ISSUP UK team, and ISSUP Global team for assisting with the development of this webinar and the ongoing series. Both of the videos that you will see of people living with people with lived experience are from the UK, and thank you to Ron and Alan for agreeing to share their experiences. Just a short disclaimer, please note that this webinar is provided for informational purposes only and does not constitute medical or treatment advice. The views presented here are those of the speaker and not necessarily those of ISSUP. Our first speaker today is Professor Liezille Jacobs. Liezille has a doctorate in psychology from Stellenbosch University. She has worked in public mental health in Washington, DC, Wuhan in China, and Antwerpen in Belgium, and at various science councils in South Africa on substance use disorder related research. Currently, Professor Jacobs is the head of department in psychology at Rhodes University. Very warm welcome to Professor Jacobs, and we look forward to your presentation.
Thank you, Roger. Thank you for the warm welcome, and thank you for inviting me. I just want to check if you can hear me clearly.
We can hear you clearly.
Great. Okay, so I'll start my presentation. It's basically focusing on the language of stigma and alcohol use disorder. So, biased and stigmatizing language affects persons with substance use disorders, which then poses significant barriers to treatment and maintains social, legal, and health inequalities. So language such as alcoholic, substance abuser, opiate addict or junkie, for example, tend to elicit explicit negative bias towards those with substance use disorder. Instead, the public and mental health professionals in particular should use person-first phrases such as a person with a substance use disorder or a person in recovery. These are more appropriate to reduce stigma, but also many research has indicated that autonomy regarding self-labeling should ultimately be conceded to those individuals who identify as being in recovery. You can turn to the next slide, please. So in this presentation, I will be discussing the findings of a narrative study I conducted with 10 women who are in alcohol use recovery and AA members. And the title of this research that I will be discussing is Women's Secretive Drinking and Their Barriers to Accessing Treatment. So when you think about secretive drinking, where would you find people or women in particular to talk about secretive substance use? AA came to me as a first place because in its title it says anonymous, and so those were the people who were in recovery and who were sort of sober for more than 6 months. They were included in my sample, and it was a sample of 10 women. Okay, so let me then just continue and then tell you what. My screen is stuck. So basically, if you go back to the previous slide, I will be talking about particular findings within the study which relates to this presentation, and that's understanding the stigma of alcohol use disorder through a gender lens. And I will particularly be focusing on cisgendered women. And then I'll talk about something that one of the participants said, which was very striking, about how stigma really contextualizes women's experiences and separates it from men's experiences, and how women are often labeled as being low-class citizens because of their drinking. Manifestations of the discourse of suffering in silence will also be discussed, as well as a way forward. You can turn to the next slide. So women with alcohol use disorder experience the associated stigma differently than men. A good example of this is alcohol use disorder amongst pregnant women and mothers, which offers a very good illustration to why sometimes they don't seek treatment because of the stigma attached to being a mother who's drinking while pregnant. Public discourses and policies with regards to women who have alcohol use disorder are condemnatory, blaming, and unsympathetic. Society tends to tolerate some behavior exhibited by intoxicated men, but if women display that same behavior, they are viewed as indecent. A significant consequence of alcohol use disorder stigma amongst women is denial, secretive use of alcohol, which sequentially leads to barriers to seeking treatment. Next slide, please. Okay, so against this socio-political backdrop, of how women experience alcohol use disorder differently to men, the participants in my study on women's secretive drinking and what stigma is attached to alcohol use disorder for women, the following excerpts Can you go back? I just paused because there was a bit of a noise. I thought we'd just allow that person to enter and then mute. So the following excerpts explain what, in their minds, in the participants' minds, is an alcohol use disorder. So one participant said, I thought that alcohol use disorder was being a hobo, meaning a homeless person, someone who drinks 24/7, which I couldn't do. My dad drank so heavily when I was a child, so I thought I could never be like him. So I resented the term alcoholic. My father was a social alcoholic. Every time he drank at a party and was out of control. Another participant said, a hobo, or like my parents, fighting, violence, doing all sorts of weird stuff, hiding bottles of booze. That's what an alcoholic meant to this participant. Another participant said that an alcoholic is my husband, a person who has lost so many jobs you can't even count, a person who does not provide for his family, a person who sleeps on a bench and who doesn't come home. That's an alcoholic. So you can see why initially when I asked the participants what they thought an alcoholic was, these were the perceptions that they have had of an alcoholic. Okay, you can switch to the next slide. So again, the participants in the study resented the term alcoholic being used to describe their problematic drinking or heavy drinking. And the following excerpts illustrate this sentiment. So one participant said that I didn't want to be labeled an alcoholic. The stigma just killed me. A female alcoholic is even worse. Another participant said, my dad told me that I was an alcoholic. I was very mad with him because I was so much in denial. Another participant said, my drinking was never a problem for me until I walked into the fellowship. And in this sense, the participant was referring to AA being a fellowship. It was other people who had a problem with my drinking. I was always thinking that I'm drinking way, way, way too little to be called an alcoholic or to look for help. So as you can see, this is a trend amongst the participants not wanting to be labeled as an alcoholic because of the stigma attached to it. Next slide, please. Okay, so this one participant was very striking for me, what this participant said, and I thought that I would just highlight this because it so much relates to what we're talking about. So against the backdrop of their social situations, the women in this study experience being chastised for their alcohol use disorder. This powerful quote, which I'm about to read from one of the participants, supports the claim that women in this study were afraid of the stigma associated with their alcohol use disorder. Society views women who drink as low-class citizens. She must get a life. She has nothing. You find most women that drink are housewives. They don't have a social life. This particular participant states that I had nowhere to go. I was at home. When you don't work, it becomes part of your daily life. And this meme that I strategically placed on this slide is a sort of a a short clip of a woman who's part of this reality series called, I don't want to say Desperate Housewives, but something to do with housewives. And this particular person everybody had a problem with her drinking except her. So if you can continue to the next slide. So I came up with this diagram after analyzing the 10 narrative interviews. And so I must say that when I say narrative interviews, it means that I spoke to the participants from the moment they picked up their first drink. They might have been 9 or 10 years old, experimenting, up until they put the bottle down. So I went through this whole life story with them, and some of the interviews lasted 4 to 5 hours. And then it brought me to this conclusion on how women become secret drinkers. They are forced into shameful isolation, shadowed by secret behavior. The alcohol use disorder amongst women search to find the hole. They search to find a hole that was caused by loneliness, pain, and suffering with alcohol. And this is how stigma forces women into shameful isolation. The fear and the anxiety that women experienced when they realized that they were dependent on alcohol, the fear of being labeled an alcoholic, was so great that it compelled them to drink in secret. Next slide, please. So now I would like to shift the gears a bit and bring you into the picture of how this secret drinking had manifestations of discourse of suffering in silence. There were various activities that the women in this study did in silence. There was a code of silence when they hid the alcohol, and there was silence when they drank in secret. The shame and the guilt the participants felt regarding their drinking and its consequences while they were engaging in the covert behavior were done in silence. The significance of this discourse of silence could be found in the denial that they have a problem and the barriers that it creates in accessing treatment. So to support this analysis, I just want to read a few of the excerpts of what the women who were drinking in secret went through. One participant said, "Early in the morning, I was shaking. I must have alcohol immediately in the morning. I put the alcohol in a sports cool drink bottle to hide it in different places from him being the husband. First thing in the morning, I had to get up quickly and get one of those bottles so that I wouldn't shake and that I could at least prepare his lunch." Another participant said, "I think my drinking got worse because I was lonely. By now it kicked in that I didn't have a partner. I'm alone. How am I going to cope with these 4 children? I lost my house. I owed people money, and now I must go to work. I was a housewife all along, and now I had to go without having a career. I couldn't stay with my mother." Another participant said, "I didn't want to disappoint them. They were my backup financially. I needed to be the good girl. I lived 800 kilometers from them. I moved away from them." This them she's talking about is her family, her parents in particular. "I needed distance so that I could drink. My younger sister and I partied together, and I begged her not to tell my parents. I know my sister called my parents once and told them that I had a drinking problem. My dad told me I was an alcoholic. I was very mad with him because I was so much in denial. I always asked people not to say anything to my parents about my drinking. I had this double life. So, the participants' silence about the real problem that keeps them drinking is significant in that it highlights that they have not accepted the real reason why they are drinking and hence have not explored alternative ways to coping with life stresses at this point in the study. However, as the study progressed, they obviously told me about how they found the rooms, meaning AA, and how they then, became people living in recovery. The next slide, please. So, to end off my presentation, I just want to highlight a few things. So, stigma and language used by healthcare professionals, mental health care professionals in particular, the kinds of words that service providers use towards women with alcohol use disorder, when they're pregnant or not, can convey either respect and encouragement or mistrust and dismissal. So, meaning they won't engage with any treatment because of the stigma that they are experiencing. Stigma and language used by the general public is very problematic for people in recovery. So, how language is used by the general public affects conceptions and beliefs about those with substance use disorders and or alcohol use disorders. And so language used by the public, including, formal media outlets like movies, for example, can greatly influence attitudes and implicitly promote discrimination towards individuals with substance use disorder or alcohol use disorder. So, to summarize, common terms such as addict or junkie otherize individuals with substance use disorder and cast a strong negative image. The routine use of the word addict in our culture perpetuates stigma and impedes the growth of harm reduction initiatives. So while books, newspapers, movies, and television can be used to raise awareness and share important humanizing narratives, unfortunately, they often use language that can undermine positive regard held towards individuals with substance use disorder. I'd like to end off my presentation by asking everybody on the webinar, how do we end non-stigmatizing language? Thank you.
Wow, thank you, Prof. Jacobs. That was very, very interesting, very informative. We do have a few questions that we will deal with during the question and answer session. But thank you for that very informative and insightful presentation. We are going to move on now to watch a short video from a person with lived experience, and then I will be back with you.
Hi, I'm Ron. I'm an addict, an alcoholic, and also have 3 mental health diagnoses. The last 30 years I've been struggling with alcohol, drugs, and my mental health. I've been admitted to a psychiatric ward about 6 times for mental health issues. been admitted to the hospital about 32 times because of alcohol issues, and my challenges were always that in the mental health services I had trouble disclosing my addiction and alcohol troubles, whilst when I had the support of alcohol and drug services, I had trouble to disclose my mental health issues. So for many years I prescribed myself with alcohol and drugs to deal with my mental health issues, and I didn't do anything really with my mental health because I never disclosed it. A big change came about 15-16 years ago when I finally when I tried to end my life, and I thought I have to change something if I want to continue with my life. I have to do it either different or decide again to end my life. So I choose to live again, and at the same time I had to do action. And one of the things of the action was to be open and not to be afraid of the stigma again with related to mental health, and in the mental health services not to be afraid of anymore to disclose my alcoholism. I went into Alcoholics Anonymous and Cocaine Anonymous, but it felt difficult or almost impossible to disclose or talk about, to share about my mental health challenges, and so it took me a long time, to finally find some permanent clean time, permanent dry time. The big changes came when I found Dual Diagnosis Anonymous, where I can talk both about my mental health challenges and my addiction. And also at my work, I work for a mental health team now. I was made a peer where I can use my own experiences to help others and to share my experiences to instill some hope and strength into people by using their own personal information and not to be afraid anymore of stigma.
Thank you, Ron, for sharing that with us. It's always good to hear from people with lived experience. Our next presenter is Mr. Paul Ashley, a substance misuse expert with over 25 years experience in health and social care, criminal justice, and substance misuse sectors in both clinical and managerial roles. His main area of expertise is focusing on service intervention portfolio development, as well as supporting services. Can I just ask everyone to check that they're on mute, please, because there's a lot of feedback. All right, so his main area of expertise is focusing on service intervention portfolio development, as well as supporting services through change management in commissioning or transfer of provider scenarios. In addition, a designer of group programs for clients and training packages for recovery workers across a variety of topics surrounding drugs and alcohol. Paul has worked in residential rehab, prison, adult community services, primary care, hospital, and criminal justice settings. His most recent work is conducting a pilot his most recent work is conducting a pilot project focusing on including substance misuse expertise in a mental health urgent care setting. Paul, over to you.
Hi, thank you. Hello, everybody. Yeah, so just to give a very brief just background to this was obviously a pilot study that I was invited to look into, and it was primarily looking at around bringing substance misuse expertise into a specialist urgent care mental health setting. So the mental health setting was new for me. But today I've adjusted the presentation slightly, just because I won't go too much. I'll give some background. I won't go too much into the pilot in any real detail. If people want to discuss that at a later date, then they can always contact me. But I wanted to shift it slightly into the terms of, obviously today's topic is around stigma. So yeah, just a little bit of what I just said there. So yeah, initially done for a trials basis that started April 2021, and it was based down at the Hospital Emergency Mental Health Services at the Eastbourne District General Hospital in Eastbourne in East Sussex in the UK. And that included the urgent care lounge and the A&E department. And it was primarily driven when I was initially approached because of the frequent presentation of people to emergency services with the significant overlap of the presence of drug or alcohol use, as I'm sure that people are aware of. And there's just some general statistics looking at around, this is around from January 2001, so a little bit old, but just gives an indication of the kind of levels of presentation that, that in 1 year there were over 7,000 hospital admissions for drug-related mental and behavioural disorders, but 16,994 hospital admissions for poisoning, and 99,782 admissions with a primary or secondary diagnosis of drug-related mental and behavioural disorders. And the pilot was looking at the efficacy of basically if they were on site expertise and whether that could prove useful. Interesting. I don't know why the slide is not moving forward. Now it is. Yeah, so basically when I was first approached to do the pilot, it was quite a blank canvas, and really I kind of there was kind of just a four what I call four core pillars that I was being asked to focus on, and then kind of flesh it out as I went from there. And the main thing was that when I was on duty, we'd be offering interventions to patients presenting at the urgent care services. And the urgent care services are split between liaison and crisis teams, with COSM is the abbreviation used in the UK for co-occurring substance misuse and mental health conditions. I was there also to support staff and colleagues in those teams with expertise, you know, in the wider case management, and also to develop and deliver internal training around substance misuse, and also to facilitate greater working relationships between our services and the various community agencies, so that there would hopefully be a smoother handover and signposting into services from those emergency presentations. Just to briefly say, it was the pilot was initially a year, and it was extended for a further 6 months. The main key after the initial review was they were looking for an increase in numbers and activity, clear evidence of content of interventions with patients and impact of substance misuse on mental health, and looking at further detailed KPIs to be developed with the service management. And for that, at that time, I didn't have access to the data, but trying to see if there was a correlation between any interventions and any impact upon representations. Just to give an idea, that there's some background supporting literature that is useful for the kind of context and what proved, you know, informed my moving forward. It was a pertinent piece of work because to do at that time, a big publication in the UK here was Dame Carol Black's review of substance misuse, the state of the drug and alcohol treatment and drug situation in the UK. And that review informed the new UK National Drug Strategy in 2021. I think it's fairly honest and open to say that the Dame Carol Black review was fairly critical of the drug treatment system at the time, because of approximately a decade prior of reduced investment and reduced oversight and coordination, and there were a number of recommendations, and I certainly would recommend sourcing that document and looking at that for you know, kind of her comments and recommendations. That informed the drug strategy. Obviously there's a lot of stuff in that, but one of the big issues focuses in that drug strategy that obviously I was concerned with was a greater working together and integration of mental health and substance misuse services. So this is kind of an idea of the scale of what I was given. So I was a whole-time equivalent of 37.5 hours a week, but it's a 24-hour service. So it was kind of looking at when I would, when initially started with the core hours of me just 9 to 5, but obviously at 24 hours I could only be in attendance when I was there. So it was looking at sort of daytime and nighttime hours, trialing about when supply and demand. That's difficult to predict, really. There was some activity over weekends, but demand could ebb and flow throughout a 24-hour cycle and throughout weeks and seasons with not really any emergent kind of particular correlation. Yeah, it was it went back to the core just because there was only one of me, and I could only obviously only do what I could do when I was there. Just in case if anyone not familiar, study the standard tools that I was using part of the assessment, and these are standard within the UK, are the audit, the alcohol use disorders identification test, the SADQ, which is about severity of dependence, and the drug abuse screening test. And they were just the initial screening tools I used so that there was some empirical scoring for when I was putting records of interventions. And just to kind of summarize about the things that I would be doing. So when the activity that I engaged with patients over the time was brief interventions, further going to see some motivating learning. So looking at better where that individual is. Obviously, a lot of these interventions are circumstance dependent, so it would depend on the presentation of the patient, their level of intoxication, their emotional state. Some things were more appropriate than others, so it was very much about assessing that and judging that at either the point of presentation, or if they were with us for a little while, perhaps we, doing that a few hours later. Obviously, it would include a full assessment of their substance misuse history and engaging their current consumption, giving some advice and information, particularly focusing on harm minimization in the immediate time period. But a big part of the work was around supporting individuals presenting with concurrent alcohol dependence, and I mean physical dependence. And a lot of that, after time, I got asked to kind of support in the main hospital up at some of the wards, particularly things like gastroenterology, where Eastbourne's demographic is fair to say slightly older, or a lot of retirement. So there's generally the presentation population is older, and it was quite common that people would present with one issue and end up being hospitalized. And whilst they're going through a process of, treatment, whatever that might be, it could often emerge that the individual was actually physically alcohol dependent, and often on the wards, it was at that point that became an issue that needed to be managed and dealt with before the primary presenting issue could be further acted upon. And yes, signposting, referral on. So these are just just a quick idea of the kind of presentations. The number of patients that actually agreed to an intervention when they presented and identified was just under 70%, around 30% declined to see. Just slightly over more as male, but not as dominatingly male as perhaps I first expected. I had no one presenting who identified as non-binary. And 46 for referrals and 66 for contacts received an intervention, accepted a referral and attended a referral at a community service. Some information there about the percentage of safeguarding cases. I think the key point really kind of looking at here is 72% of the presentation are people who had previously had contact with the urgent care services. So we were dealing with a, to use a phrase, revolving door population. And that was only 30% who were first time. And again, looking at the presentations of the primary drug, I did record secondary and tertiary drug presentations, but for the brevity of today, I've just put the primary. But as you can see, they're overwhelmingly alcohol, which obviously says a lot. The age of the presentation was between 18 and 80 years of age. That was the lowest age and the maximum age that I had contact with, and that's a spread of 62. The median age is 49 years, and the mean average age was 38. So getting on to stigma and prejudices, I want to be careful here. I want to make sure that when I'm making my comments, that this is in a context of a long period of time. And I started the pilot just towards, well, halfway through the pandemic. So it was a particularly stressful, pressured time. There were obviously extra measures in place. And I think it's fair to say that I did frequently hear comments around presentation of substance misuse that, in my mind, could be interpreted as frustration with that client group. That is something that I raised with management, and it is something that I did discuss with the team in team meetings and that. And there wasn't, I want to stress, there wasn't a lack of acknowledgement by the staff. But I think if you look at the points I've just put up on this slide here, I did reflect that personally as a family member of someone who has accessed those services in the past, those comments made me feel uncomfortable to know that, you know, certain things about, but I guess a degree of blaming of the client for their drug and alcohol use. But I think ultimately, those comments came out of a frustration that this team were facing, were working with individuals who were frequent presenters and repeat presenters. And I think the frustration came that they did what they could within the scope of their role. I'd like to think that some of my participation when I was available helped to some degree, but I think what it further exacerbated for me was the situation which the drug strategy itself highlighted, and that is the split between substance misuse and mental health services, and still very much a lot of work there is to do for those to be greater integrated, understanding of the, you know, the overlapping of the conditions, the comorbidity, and finding joint working in the community agencies that are more efficacious. You often get in scenarios where one service might engage someone very quickly, but the other might take some time, or there might be waiting lists. So what you get is kind of one thing trying to be addressed when the other, and the gold standard practice is recommended that in these cases, you know, in co-occurring conditions, ideally both things need to be met in a joint approach, a partnership working approach, so that the client isn't trying to sort of try and manage one issue whilst the other one is still remaining unresolved. So yeah, I did observe that kind of silo mentality, and I think it's fair to say that again, this isn't necessarily critical, but of them as individuals, but the management of respective substance misuse services and mental health teams, because their way their services are commissioned and set up, they feel that their priority is towards obviously their own respective performance targets and funding profile. And so it kind of asks a lot of existing strategies, existing frameworks. It asks a lot of the individual service management to step out and go the extra for the integration, without really, I think, the kind of oversight and leadership at a higher level that might be covered. Eventually, it's asking them to be brave. And that at a time when there's, you know, various issues, particularly, again, I'm saying this was during the pandemic, was probably slightly an ask too far. But as again, you know, a lot of the practice talks about the concept of no wrong door, and that's the idea that with someone with a co-occurring condition, whether they present a mental health service or a substance misuse service, whichever they do first, it shouldn't matter. You know, as I said before, the idea is then that is dealt with in an integrated, joint managed approach. I've similar things just to exacerbate with the A&E staff themselves, but often they spent managing intoxicated clients with alcohol and behaviour, as I'm sure is fairly, you know, obvious to people. Sometimes in those presentations, a lot of the time was meant managing the intoxication behaviour and waiting for some of that to wear off before they could really conduct an accurate assessment or engage in a meaningful way to, you know, with the patient. And that included staff present, including reception staff and security staff as well. So it is recognised that it is it is an environment not fully conducive always to as meaningful intervention as would like to be. As I mentioned before, I offered some support to other departments, and I think the big one, as I mentioned a little bit earlier, was very much around alcohol dependence and detox regimes. Particularly, there was a few examples of, as I mentioned before, the scenario where people would present for an initial issue, and then it would be emerged that they are physically dependent to alcohol, that the medical staff would ask for support because they had significant lack of knowledge around drug and alcohol issues. And I think that is certainly something that you know, would be quite useful in sort of general medical training, really moving forward, given the prevalence of these issues. So some mixed outcomes really, but general. The report was fed back to the senior management board of the trust. The outcome in terms of the representations, I was unable to fully get to because of some of the dates that are unavailable. It was looking at the consideration that with funding they may consider further forward a half of the whole term equivalent. Some feedback again, and I was a bit disappointed, but that it was felt that ultimately the work fell under the role of the community substance misuse service, which is kind of reflects and reinforces a little bit the comments I just made about silos and kind of protectivism, really. The report has also been forwarded to and discussed with the Department of Health and Social Care in the UK and East Sussex County Council's Strategic Commissioner for Substance Misuse. And that's the end. I hope that was useful. Thank you.
Thank you, Paul. Very interesting to see the work that is being done there. We have had some questions coming through, which I will bring. I will pose a little bit later. Just a reminder to all attendees: if you do have any questions or anything that you would like to say, please feel free to post it in the questions box. We are going to have a quick video now, another video from a person with lived experience, and then we will go on to the Q&A session.
Hi everybody, my name's Alan Butler, and just in the way of a little bit of background information about myself, I made recovery in 2009 from 32 years in active addiction and active alcoholism. I had a major drug and alcohol problem for all those years, starting with drugs. My first problem was with heroin and cocaine, and that lasted for 22 years, and then I managed to put down the drugs but picked up the ball. So I spent a further 10 years in active alcoholism. I'm going to try to be precise today because I know that the topic is stigma, and I just want to talk a little bit about my experience of stigma. When I made my recovery in 2009, although I had a problem with just about every substance under the sun, I made my recovery using AA, NA and CA, right, all single purpose fellowships. Right, and in single-purpose fellowships, right, you know, the primary objective of the fellowship is to carry the message to the still suffering alcoholic and addict, right, and anything that detracts from that, such as talk of medication, side effects of medication, mental health issues, right, is kind of unwelcomed, right, and that's a kind of given across all fellowships. So therefore, when I made my recovery, I made it with AA and the single-purpose fellowships for two reasons. One was that, you know, DDA did not exist, right, at that particular time. And two was because at that particular time, I would not have agreed that I had a mental health issue. Although I'd spent many times in psychiatric hospitals, right, I would have always argued that all my mental health problems came from my addiction, that my addiction came first and the mental health stuff came second. But the further I moved into recovery and the further behind I left my addiction issues, the more I realized just how much my mental health had played a part. Right? And I really wanted to discover that and delve into that. But I kind of realized that in single purpose fellowships, there was no availability, there was no chance to talk about mental health. So there's a sort of stigma that you feel from even people in fellowship, right, towards mental health. Right? And there's also the stigma that you place upon yourself, right? Because you recognize that speaking about mental health in these forums, right, in these fellowships is not welcome. So you close down yourself, right, and you don't talk about these issues, which then means that you're not going to get the identification. If you go to any fellowship room, right, there may be 30 people in there. Of them 30, maybe 15 have got mental health issues, right? But nobody speaks about it because it's not welcome. In 2016, I began, well, I was the co-founder of one of the co-founders of an organization, a fellowship called Dual Diagnosis Anonymous, a 17-step program, which was founded in America 20 years previous. And it came over to England, and myself and my partner got involved in trying to get that off the ground. And it's been such a roaring success because the 12 steps focus on the addictive side of a dual diagnosis, but they have 5 additional steps which focus on the mental health side of a dual diagnosis. Right? So it became a completely suited fellowship, right, for those struggling to live with a dual diagnosis, and it liberated them in the sense that they was able to talk openly in a room of their peers and receive positive feedback, because that's also possible in DDA, right? You know, so it was such a liberation to people. This is what everybody has said, to be able to talk about both issues that they're struggling with in the one room and receive positive feedback.
Thank you, and again, thank you to ISSUP UK for organising those, and that was Alan talking about his experience with dual diagnosis. So I am going to pose a couple of questions that have come through on the questions box. If I can invite our presenters to rejoin us. I think the first thing I wanted to just raise here was in relation to Paul's presentation. There was a comment made by Martin, and he says that although, to be clear, the UK strategy is in fact the English strategy, and on the whole does not link to Scotland, Wales, or Northern Ireland. And I think that this is a very, very important point to, I mean, Paul, you spoke about context, Prof. Jacobs also spoke about context, and I think it's very, very important that we acknowledge that, you know, stigma is not the same around the world, and substance use itself is also not the same around the world, experienced very, very differently in different pockets. Is there anything that you'd like to add to Martin's comment, Paul?
No, just that absolutely. And I know even within the UK at the moment, the trend still is very much that Scotland feel very much with their own recent drug-related deaths. It's been a big issue in Scotland sort of the last year to 18 months, that they feel they've got to very tailor things quite specifically for their situation. So absolutely, yeah.
Absolutely, and I agree with that. I mean, here in South Africa, it's the strategies that might work in Western Europe or in America might not necessarily work in our context. So I think it's very much about how do we find a fit for our context and work towards lowering that stigma within our own practice. Thank you. The next question for Prof. Jacobs, about the woman. The society is harder with them when the alcohol appears. So how do we work with the stigma and at the same time not be condescending?
That's a difficult question to answer, because some of my other work that I do is on, you know, gender responsive healthcare. And I think the best thing we can do as healthcare professionals, in particular, mental health care professionals, is to, you know, train up. So, for example, in the US, you cannot get your license renewed as a practitioner if you don't attend gender responsive healthcare training. And so every year you have to go to, you know, for training. So I think the best way for us to reduce the stigma is to read research, inform ourselves about what's happening, how to handle people, and also to give people the autonomy to self-label themselves. You know, we often try and take the power away from women in particular and label them, as we've also heard in Paul's presentation, the same kind of thing where healthcare practitioners think that, you know, patients can't hear them, and then they just label them accordingly, thinking, oh, they're drugged up or whatever, and they can't respond to what they're saying. But words hurt, you know, and I think that's what keeps people away from treatment. And also I think that's what makes people go down the slippery slope again, and then have to come back and sort of educate themselves about how to go about their recovery process. So it's not an easy question to answer, but in short, just to consistently train ourselves to be informed and to read up on research on how women prefer to be handled in a treatment setting. Women-centered treatment facilities for substance use disorder is very scarce globally, but that would be the way forward, where women can actually bring their children to treatment centers, or, you know, in circumstances where we live in South Africa, most treatment centers don't have the facilities to handle women who are pregnant. When I say handle, I mean, you know, if there's a complication with a pregnancy, they don't have the necessary staff or funding available to have that staff to to help women in recovery who are pregnant. So there are a lot of challenges, and it's a multifaceted answer to a very complicated question, but I hope my attempt was successful.
Thank you. Yes, it's not a very easy question to answer, that one, because there are so many different aspects that are involved in assisting people in that, or women in substance use treatment centres. So yes, thank you for that response. I suppose it would bring me to the next question, which sort of ties in that, and I'd like both Paul and Liezille to sort of consider this and give us a bit of feedback. It's from Diana, and it says, what would the best practice methods used or tested, what were positive with changing the community views of substance use? So she's asking what if any, are there any best practice methods that have been shown to lower the community views within on substance use?
I think anecdotally, a couple of things that have worked quite well are certainly peer involvement has been useful. And if just for a second, I can be a bit more specific about alcohol, although obviously it's generic. When peers have become involved, and then they help bridge that connection between the community and services, and often what very active peers have done. And I worked with a couple of very supportive representatives from AA whilst I was doing the pilot. That's something I omitted actually, but they helped to demonstrate that you can use the classic, as the first presentation talked about as well, about the perception that alcohol might be someone who's a hobo or a street and homeless, and actually it helped present rather the fact that no, these are people from a broad range of spectrums, from otherwise ordinary, in commas, ordinary lives, from professional backgrounds, from a range of ages, and it helps show, I think, that dependency can be identified much more comfortably amongst the other range of issues you might go to see any other healthcare provider for any other issue for. You can, I hope it doesn't sound glib, but that it moves substance misuse a little bit more into the mainstream, and that it's a medical issue that people need support and treatment with, and it's not just affects marginalized people on the edge of the community.
Can I respond, Roger?
Yes, please. Yes, please, Professor.
So my response is more the best. If I would think about what best practices would be in an ideal society, I would like to think that the ecological systems theory approach, the Bronfenbrenner approach, which looks at first, the nexus, which is the family. And usually when people do go for substance use disorder treatment, the family is also called in for psychoeducation about what the person in recovery is experiencing. And I think in that sense, if we start with the family and then go broader to the community, and when we get to the community phase, I already see programs being rolled out by some NGOs that deal with education, psychoeducation at basic education level, which is primary school and secondary school. And then when you get to tertiary education, which is the level I'm at, we also have specialized people like Roger come in and train students and conscientize students about, substance use disorder. So again, like I said, it's not a one, sort of one thing fix everything. There's a system that we need to sort of access, that's not only involving mental health practitioners, but public health practitioners, educators, parents, you know, like Paul said, peers. Those are the kind of best practices that I've seen that has had great success in communities that are, you know, rife with substance use disorder.
Thank you both. Very interesting. I think we could be talking about this topic all day. Prof. Jacobs, while you're here, there's an interesting question by Jefferson, who asks, what are the best practices in dealing with stigma of substance use disorder victims who are pregnant? He says, he goes further and says, I have seen pregnant women stigmatized due to their addiction in Liberia. I think this is a very, very interesting question, because it raises not just the idea of stigma, but also how people or pregnant women are viewed when they have an addiction.
Yes, so I have a master's student who is busy doing a systematic review on decriminalizing women who are pregnant and use alcohol. And what we are doing with this study is basically looking at policies throughout the globe that govern pregnant women who drink alcohol. So, for example, there was a policy or a white paper written by the Western Cape Department of Health in South Africa, which indicated that there was a threat for, you know, women who present as being pregnant. So they are obviously showing, they might be 6, 7, 8 months pregnant and are showing, and they go to a grocery store and they buy alcohol, and then it's the responsibility of the establishment to report this woman to the police. And so there's a lot of, you know, questions going on in Parliament about how is this evidence-based, but also there's a lot of policy implications about the right of a woman. She might not even be consuming this alcohol. It could be for a dinner party that she's arranging, and that she's buying the alcohol for her guests and not herself. And so those kind of you know, debates are constantly happening within the public sector where policy is developed. But on a more, you know, a more sort of, you know, basic point of just trying to answer your question directly, there isn't really support for women who struggle with addiction. So this is not, let's say for argument's sake, we're talking about women who are not, you know, living with alcohol use disorder while they are pregnant, versus women who are living with alcohol use disorder. The access to treatment for women with alcohol use disorder is very difficult if you are just, you know, a normal person who doesn't have access to medical insurance and can be treated at, you know, a private hospital or something. So people who are living in impoverished areas are very highly affected by this. And so in the world currently, unfortunately, I don't want to admit this in a public forum, but South Africa is #1 in the world for FAS and FASD. And that just shows you how great the need is to deal with women who have alcohol use disorder and are pregnant. And unfortunately, we can't do anything without the assistance of public policy to enforce some kind of, you know, treatment at non-governmental level, governmental level, and have, you know, the private sector come to the party as well.
Mm-hmm. Absolutely, and that in itself, I think, is a several PhD or master's studies, and I think it's very, very pertinent, and an area that is often over or often neglected. in terms of substance use disorder treatment, but also in terms of prevention of substance use disorder. The next question, and we're going to start wrapping up soon, I'd like to pose to Paul, and it's another one from Martin, and he says, I would take the view that the term addict is stigmatizing, and is a problem with the 12-step which uses language, tends to use the word problematic. How do we deal with that, Paul? I mean, how do we look at it? I mean, Alcoholics Anonymous, if we're talking about not using stigmatizing language and the word alcoholic in itself is stigmatizing, how do we deal with that going forward?
Yeah, that's a difficult one. That's a good question. And I'll profess I don't really have the answer. I guess my immediate response to that is, specifically within the culture of AA, that is very much part of the organisation's environment and philosophy and culture. Speaking from someone who's traditionally coming from the kind of service approach and research approach, is just to continue to be mindful and promote within that alternative language and not really labels, that's not construct, but certainly trying to avoid that. And as mentioned in the earlier presentation, instead say people with certain conditions. For instance, and I think I'll give you one small example that's quite encouraging, is dual diagnosis is something that's sort of being moved away from, and instead is now, you know, the label more is a co-occurring conditions, which you know, that, you know, to anyone who didn't know immediately that we're talking about substance misuse and mental health could be two other completely different chronic illnesses.
I'd like to add, Roger, if you would allow me, to what
Yes,
Paul has said. So we must remember that Alcoholics Anonymous, Bill's big book, was, you know, written in the 1950s. And so, you know, we have to look at the context in which these phrases that we are now questioning, and if we look into, you know, the gender spectrum, for example, was like cisgender, that didn't exist in the 1950s. So it's our job as you know, mental health practitioners, researchers, to sort of, you know, approach organizations and tell them. And that's why I mentioned in my presentation that words like addict or junkie or alcoholic is part of our culture, is part of just rolls of the tongue, because that's what's commonly used. But we who are educated need to somehow get through, maybe in the non-governmental organizations, in education settings, where we sort of, you know, speak to people and try and reprogram our minds. And I think the millennials are on the right track with using these non-labeling sort of, you know, terminology. But just to answer the question very bluntly, this organization was started in the 1950s, and I think the tradition is what needs to be addressed before we can even, you know, look at the word Alcoholics Anonymous.
Absolutely, and I agree with you, and I think, I mean, we've mentioned it a couple of times. You've mentioned it, and Paul's mentioned it. You know, context is so important, and we have to acknowledge the context where all of this is coming from, and it's important not to overlook something such as AA that has worked for so many people for so long, just because of one word that they use on historically been using for such a long time. I suppose, I mean, you know, if we take that question, it really ties in with the last question I'm really going to pose. Actually, there's two questions. What would the terminology be that we would use? And this is a question that is coming from someone did post it. It was Raya. They posted, what is the appropriate words that can be used to break the stigma around substance use? And I posed that to both our presenters and any of the panelists that are on the link. Any responses? What are the best words that we can use? I mean, what language can be used to avoid stigma?
I think I mentioned it earlier, Roger, when I said that we should also give people the autonomy to self-label like we do on the gender spectrum. We allow people, we ask people, what is your preferred pronoun? So I think to start off with the person itself and ask them how they identify. Most people would prefer I'm in recovery, because it's a lifelong sort of, thing that you deal with. Most people would say I'm a person in recovery. And a lot of my participants, when I gave my presentation, they said that the word alcoholic means that you live on the street or you're homeless or something. But person in recovery, a person with substance use disorder, those are sort of the terms that people feel more comfortable with in the research that I've done. But again, I think just to give people the autonomy to label themselves would sort of ultimately be, conceded to those individuals who identify as being in recovery or living with a particular disease. Similarly, that we would say, I live with diabetes, or I'm a diabetic, or, those kind of terms. I think that would be my contribution to try and respond to that question.
Thank you. Paul, would you like to add anything?
No, not really. I echo that. I think, yeah, I mean, language can be very powerful, can't it? And it's very culturally specific. I think when we use like medical terms like diagnosis, that feels very top down and didactic. But letting people self-label gives them quite a lot of power back, and I think also helps them, like so many other things, addiction is on a spectrum, isn't it, of severity and type and patterns. People, it's all unique to the individual. So letting the individual use their own language will help them communicate how they feel specifically their relation. Personally, I've always tried to encourage, when I've worked with people, to talk about their relationship with their substance of choice. Therefore, we can talk about the relationship in a story sense, like over a period of their history, but equally the current status, because a current status of relationship can be more or less severe than it has been previously. So that's an example there from me.
Thank you. Thank you so much. I would like to thank both Paul and Liezille for their input today. And we are running out of time. Unfortunately, I haven't been able to get to all the questions. However, we will try and get to those questions we haven't been able to deal with, and get both Paul and Liezille to respond in their in written form. I want to thank everyone for joining us today, and if you've really enjoyed the session today, please make sure that you register for our next session, which is coming up to be held in July, where the dates will be communicated with you. And that session is all about stigma, family, and community. So a lot of the questions have been focused on that today, so you will get more information that will be provided in that session. The session after that is all about stigma and gender related to women and the LGBTQI community. So please watch out for the links and registration links to those webinars. And once again, thank you so much to everybody that has interacted with us today. Thank you for all your questions. Thank you for joining us. And again, to our experts, Professor Jacobs and to Mr. Paul Ashley, thank you so much for availing your time. A very, very interesting topic and very, very interesting presentations. Thank you so much.
Thank you. Bye.
Goodbye.